Hello, I'm Professor Emily Mercury, and this is Chapter 20, Psychotropic Medications, Alcohol, Drug Abuse, and Withdrawal Treatment in Essentials of Pharmacology for Health Professions, 9th edition. Chapter Objectives. Upon completion of this chapter, the learner should be able to categorize the most commonly used psychotropic medications according to the following classifications: central nervous system stimulants for promoting wakefulness and treating attention deficit hyperactivity disorder, ADHD, antidepressants, anti-manic agents for bipolar disorders, anxiolytics, and antipsychotic medications and tranquilizers. List the purposes, actions, side effects, interactions, and precautions and contraindications for psychotropic medications in common use. Explain the treatment of acute and chronic alcoholism. Describe the effects of commonly used illegal drugs. And list the responsibilities of a healthcare professional in combating drug abuse. Psychotropic medication classifications. The word psychotropic, if we break it down to its root words, psycho means mind or soul, and tropic means turning or having an effect on. So psychotropic refers to any substance that acts on the mind. Psychotropic medications exert a therapeutic effect on a person's mental processes, emotions, or behavior. So when used appropriately, they will help with a condition that affects mental processes, emotions, or behavior negatively, and they will be therapeutic to help improve that disorder. Psychotropic medications can be classified according to the purpose of their administration. CNS or central nervous system stimulants promote wakefulness. ADHD agents treat ADHD. Central nervous system stimulants often are used for ADHD as well. So there are different categories of medications used for ADHD, but things that are solely used for ADHD are called ADHD agents. Antidepressants, so against depression, they treat depression. Anti-manic agents treat bipolar disorder, there are various types of bipolar disorder, but oftentimes characterized by manic episodes where the person will be hyperverbal, they're talking a lot, they're not sleeping well, they may have racing thoughts. That's called mania. So anti-manic agents treat that portion of the bipolar disorder, the mania portion. Anxiolytic medications treat anxiety. And antipsychotic agents relieve symptoms of psychosis. So what's nice about these, for the most part, their classifications are the thing that it treats is in the name itself. Antipsychotic treats psychosis. So that can help them be easier to remember. Commonly used psychotropic medications for the following classifications: central nervous system stimulants, caffeine, which it's listed here, and caffeine is a central nervous system stimulant, but just be aware it's not prescribed for any particular disorder. It's not something that we would give as a prescription. However, it does act within the body as a central nervous system stimulant. The only time that we give caffeine actually in a medical setting is in the neonatal intensive care. And for these micro preemies, these very, very tiny babies, sometimes a special form of caffeine is given via IV, and it helps stimulate their respiratory drive. Just a little fun fact for you. Amphetamine, be mindful that methamphetamine, the drug, is also a stimulant, but when we're talking about amphetamine, we're talking about a controlled therapeutic use substance, and the brand name for that is Adderall. And then methylphenidate, which is Ritalin. Both Adderall and Ritalin are central nervous system stimulants used to treat ADHD, but they fall under the stimulant category, not the ADHD agents, because of the way that they act in the body. So ADHD, also called ADD, is a chronic condition including attention difficulty, hyperactivity, and impulsiveness. And why a stimulant works on somebody with ADHD is that their dopamine and norepinephrine transmitters there's a malfunction either with the level of those neurotransmitters in the brain, or the ability of the receptors to kind of stay saturated with those. And so the stimulant helps to provide those neurotransmitters and keep that channel kind of open, which will calm somebody with ADHD and help them to focus, because their brain's not jumping all over the place kind of looking for this dopamine or norepinephrine hit, we call it. So if somebody takes a stimulant and they don't have ADHD, they're actually more likely to have their thoughts be racing and to feel very, amped up, versus somebody with ADHD, this will calm them. It has a kind of a paradoxical effect. So there's something interesting to note about these stimulants and how they work in the brain. ADHD agents, atomoxetine, which is Strattera. This does not work as a stimulant. What it does is it helps to create it helps to stimulate the body to create its own neurotransmitters. And so that works differently than giving it the body and the brain a stimulant. Antidepressants, amitriptyline, Elavil is the brand name, phenelzine, Nardo, fluoxetine, which is Prozac, and then escitalopram, which is Lexapro. All work slightly differently within the brain, but they are all under the category of antidepressants treating depression. Anti-manic agents, lithium, brand name Lithabid, carbamazepine, brand name Tegretol, anxiolytic, meaning anti-anxiety agents, clonazepam, which is brand name Klonopin, diazepam, brand name Valium, and buspirone, brand name Buspar. And then your antipsychotic agents, chlorpromazine, which is brand name Thorazine, and then haloperidol, which is brand name of Haldol. The image below shows a summary of psychotropic drugs, and this image is also in your book. I like this because on the top half, it shows things that increase central nervous system activity. You see the up arrows there. And then on the bottom half, it has things that decrease central nervous system activity, and it has the down arrows. A slang term you might sometimes hear is uppers, which increase central nervous system activity, and then downers, which decrease central nervous system activity. So on the top half, we have your central nervous system stimulants, as we previously discussed, that are used for ADHD, narcolepsy, which is an excessive sleepy, it is a disorder marked by excessive sleepiness or falling asleep when you shouldn't be, like inappropriately falling asleep. These medications promote alertness, and they can also be used for neonatal sleep apnea, as I mentioned with the caffeine. The example drugs are Ritalin, Adderall, and Cafsit. And the Strattera is going to also be on this top half as a central nervous system, something that increases central nervous system activity, but again, it's under the ADHD agent category, not a stimulant category. Antidepressants, mood elevators, they treat major depressive disorder. There are many different types. The tricyclics have pretty much fallen out of favor. They were more of the original antidepressants, but they have a lot of side effects. They are used sometimes if somebody is not responding to others, but it's more of a last resort. Same with your MAOIs, which are your monoamine oxidase inhibitors. They're an older type of antidepressant. They're very rarely used nowadays. And you can see there tricyclics, Elavil, MAOIs, Marplan. Those are not medications that most of us are as familiar with. SSRIs are the most commonly prescribed antidepressants. The example is Prozac. Many of us have probably heard of Prozac or seen commercials for that. It's a much more commonly prescribed drug. And SSRI stands for Selective Serotonin Reuptake Inhibitor. Your SNRIs, serotonin noradrenaline reuptake inhibitors, example is Cymbalta. This was developed with the thought that it would be more effective than the SSRIs, but research ended up showing that it is more effective for some people, but SSRIs are more effective for other people. So basically it's kind of trial and error which one someone will respond to. We will try one, and if that's not working, they may try the other class. And then your heterocyclics, which just act on a different pathway. The example is Wellbutrin. Those are also commonly prescribed in in modern medicine. On the central nervous system depressants, on the bottom half here, we have our sedative hypnotics discussed in our previous lecture. These are for sleep. Barbiturates and non-barbiturates, your phenobarbital, which is luminol, temazepam, which is Restoril, zolpidem, which is Ambien, and then Zaloplan, which is Sonata. You have your minor tranquilizers, which are anti-anxiety. They fall under the anxiolytic category. These are meant to calm and relieve anxiety. So again, anxiety is this kind of your mental stimulation and alertness to a point where your body's kind of reacting. So this is going to help bring it down. It's on the downer category. It's going to help depress those or decrease those central nervous system activities. The examples here are alprazolam, which is Xanax, chlordiazepoxide, which is Librium, diazepam, Valium, buspirone, Buspar, and lorazepam, Ativan, which we will talk more about when we talk about alcohol withdrawal. And then your major tranquilizers or antipsychotics. These are for psychotic behavior, delusions, hallucinations, or violence caused by psychosis. Your examples here are haloperidol, Haldol, thoridazine, which is Mellaril, and risperidone, which is Risperdal. Knowledge check. Which condition does anti-manic drugs treat? A. Attention deficit hyperactivity disorder. B. Sleepiness. C. Depression. D. Bipolar disorder. The answer is D. Bipolar disorder, which is characterized by some form of manic episodes. Depending on which type of bipolar they have, it may be mixed. So anti-mania helps treat those manic episodes. The answer is D. So going a little more in depth here, central nervous system stimulants are given for the purpose of promoting central nervous system function. We already talked about some of the common drugs, and the following chart is going to show us the use, action, side effect, contraindication, and interactions of commonly used stimulants. So those things, these use, action, side effect, contraindication, interactions, those are 5 things that we want to know about any medication that we're giving. And these are things I want you to be mindful of as you're working on your medication pamphlet as well, that you want to include that information for your patient information and patient education. So caffeine, safe and effective over-the-counter drug proven to help fight fatigue and drowsiness. It's not, again, typically prescribed. It's more something that you can get over the counter. It helps to fight fatigue at doses of 100 to 200 milligrams, not more often than every 3 to 4 hours. The side effects are tolerance. So those of you who drink a lot of caffeine, myself included, may notice that over time it's really not as useful. It's not as helpful because you grow tolerant of it. So the same amount is not actually giving you the same effect anymore. Habituation, so feeling that you need it, that it's become a habit, that you rely on it. Headaches, irritation, nervousness, anxiety, and then dizziness can occur if stopped abruptly. Contraindications, pregnancy and lactation and nursing. So people are recommended to stay off of caffeine when they are pregnant or nursing. And it does not have any major interactions that are in the literature currently. Another CNS stimulant, amphetamine and methylphenidate preparations, Adderall and Ritalin. These are typically first-line therapy for ADHD in children over the age of 6 and also given for narcolepsy. The side effects are nervousness, insomnia, and irritability. Insomnia is difficulty sleeping, so because it's a stimulant, it can make it hard for somebody to fall asleep. Tachycardia, palpitations, hypertension, and cardiac arrhythmias. Dizziness, headache and blurred vision, and gastrointestinal disturbances. as we're increasing the activity of the central nervous system, we're also causing some of these cardiac side effects as we kind of kick up the activity. Contraindications, treatment for obesity without diet and exercise modifications. So these medications can make somebody lose weight. Stimulants in general can do that, but it's typically not recommended for treatment for more than a few weeks at a time, and it's usually not used as a first line. Somebody who has anxiety or agitation, this is also a contraindication. History of drug dependence, alcoholism, or eating disorders. Hyperthyroidism, because we don't want to kick up the thyroid activity even more. Cardiovascular disorders. Closed angle glaucoma. So glaucoma is characterized by high pressure in the eye, and closed angle glaucoma is a very dangerous medical emergency. So if someone's had this, we don't want to increase the risk of making their blood pressure higher by giving them a stimulant. Pregnant or nursing women. Abrupt withdrawal, because this can cause depression, because it's kind of you're on the stimulant and then you're ceasing it automatically. Your central nervous system might kind of kick down and go to a decreased level. Use with monoamine oxidase inhibitors, so MAOIs, that can cause hypertensive crisis because they both have the risk of hypertension. And then interactions must be used with sustained release preparations differing in designations. So there are different types of release with these, but typically you cannot have this all at once. It can cause this crazy increased effect to your cardiovascular system and your central nervous system. So it's designed to be sustained release, so it releases over time throughout the body. Typically, a shorter acting is like a 4 to 6 hour, and then your longer acting is more like 6 to 10 hours. Other CNS stimulants, your wakefulness promoting agents. These are modafinil and armodafinil. These are approved for narcolepsy, sleep apnea, and shift work sleep disorder in adults and adolescents over 16 years of age. Thinking just as a nurse, night shift workers oftentimes do have difficulty getting back to normal sleep cycles, so this can be used to help treat that. Side effects, mild headache, dizziness, nausea, and anorexia, anxiety, depression, and mood changes, hypertension, palpitations, and tachyarrhythmia, so rapid heart rates. Contraindications, possible causes of fatigue and sleepiness should be determined before stimulant medications are prescribed to increase wakefulness. So this is not prescribed just as a first line. We want to first find out why somebody has fatigue and sleepiness and see what other factors can be altered before we give them a medication. Interactions, no major drug interactions noted. Attention deficit hyperactivity disorder agents. The agent here is Strattera, which was mentioned previously. Strattera actually is an SNRI, but it's not an SNRI that's used to treat depression. So I don't want you to get confused. It's in that grouping of medications, but it's considered separate because it's used as a ADHD agent. It is the first non-stimulant, non-controlled drug approved for the treatment of ADHD. So all of the stimulant medications used for ADHD are considered controlled medications because they have a high risk for abuse, but Strattera does not, which is a really nice option. The side effects of Strattera are dry mouth, reduced appetite and fatigue, nausea, vomiting, constipation, and dyspepsia, urinary hesitation or retention, an increased risk of suicidal tendencies in children and adolescents. Has a black box warning. Contraindications, narrow angle glaucoma, and cerebrovascular heart or hepatic disease. Again, we have to think about how some of these medications can affect the blood pressure, and that's why there are these contraindications. Interactions with Strattera, it will interact with beta agonists, vasopressor agents, and quinidine, and then fluoxetine, paroxetine, venlafaxine, and MAOIs, so you shouldn't be giving both of those medications or medications in both of those classes. Your antidepressant agents, the exact cause of depression is unknown, but it may result from a chemical imbalance in the brain. In depression, there may be a shortage of different neurotransmitters, including dopamine, serotonin, or norepinephrine. There are 5 categories used to treat depression, which include tricyclic antidepressants, MAOIs, SSRIs, SNRIs, and heterocyclic antidepressants, as I mentioned before. Tricyclics, the example they give here is tofranil, but there was a different example on the prior slide. This promotes chemical balance within the brain. The side effects are dryness of the mouth, increased appetite and weight gain, drowsiness and dizziness, constipation and urinary retention, sexual dysfunction, postural hypotension, cardiac arrhythmias and palpitations, and confusion, especially in older adults. Contraindications are cardiac, renal, GI, and liver disorders. Contraindicated in older adults, those with glaucoma, obesity, seizure disorder, pregnancy and lactation, and then concomitant use with MAOIs, meaning you shouldn't be giving them both together. Interactions, certain antiarrhythmics and some quinolones can cause QT prolongation if given with tricyclics. If given with clonidine, it can cause a hypertensive crisis. Central nervous system drugs and alcohol, and SSRIs, which can increase the tricyclic blood levels. Just remember that interactions means that they shouldn't be given with those medications. So if someone's already on one of those medications, we wouldn't put them on this category of antidepressant. Your MAOIs, phenelzine is the one that they give example of here, which is Nardil. They are typically reserved for refractory or atypical depression or depression associated with panic disorders or phobias. Side effects can be nervousness, agitation, and insomnia, hypertension or hypertensive crisis, which can be fatal, tachycardia, palpitations, and chest pain. Contraindications are patients with cerebrovascular, heart, liver, and renal diseases, children under 16 years of age, pregnancy and lactation, and then abrupt discontinuation. These need to be weaned down, titrated down. Interaction, adrenergic drugs and levodopa, SSRIs and SNRIs can cause serotonin syndrome and many other side effects. And then CNS depressants, which can result in circulatory collapse. Generally, I'm not expecting you to remember each and every one of these contraindications and interactions. I just want you to think about what we're trying to do within the body and why we might be concerned about the interactions with other medications that are acting on similar or, in some cases, opposite pathways. Your SSRIs are fluoxetine and escitalopram, which is Prozac and Lexapro. And as I mentioned, these are usually the first-line medications for the treatment of depression, which are preferred because of fewer side effects, as well as greater safety in cases of overdose, which also increases patient compliance. So patients are more likely to stay on a medication when there are less side effects. The side effects of these that do occur are sexual dysfunction, nausea, and other GI effects, most commonly during the first 2 weeks of therapy, anorexia and sweating, insomnia, anxiety, nervousness, tremor, drowsiness, fatigue, dizziness, and hyponatremia, which is low sodium levels. And then contraindications, liver or renal impairment because of how they are processed in the body. Suicide prone. So while, oftentimes people with depression struggle with suicidal ideation, if we already know that somebody has that, has had that in the past or has had suicidal ideation, this can actually increase thoughts of that. And so this is one we need to be careful with. People with diabetes, bipolar disorders, underweight, eating disorders, pregnancy and lactation, and then abrupt discontinuation. So the reason we talk about eating disorders is this can actually suppress the appetite, which can make the eating disorder worse. Interactions, so these should not be taken concurrently with MAOIs or anticoagulants, antiplatelet drugs, and NSAIDs because of increased risk of bleeding. Amphetamines or antidepressants, these can also result in serotonin syndrome if taken together. Your SNRIs, duloxetine, which is Cymbalta, and venlafaxine, which is Effexor. These are used, they inhibit the reuptake of both serotonin and norepinephrine. Side effects are similar to your SSRIs. The contraindications are also similar to your SSRIs, so pretty much the same. And the interactions are also similar. So as I shared before, SSRIs versus SNRIs, they work slightly differently, but they're very similar. And they tends to be that one works better than the other, just depending on the person. It's very dependent on specific, physiology of the person. So we'll oftentimes try one. If that doesn't work, we'll switch to the other one. And then your heterocyclic antidepressants, bupropion, which is Wellbutrin, and mirtazapine, which is Remeron. Useful in cases of severe depression characterized by extreme fatigue, lethargy, and psychomotor retardation. So somebody who's very fatigued, slow moving, this is very severe depression. The side effects are drowsiness, insomnia, restlessness, agitation, and anxiety, dry mouth, nausea, dizziness, and confusion, priapism, which is prolonged penile erection, or impotence, which is inability to maintain an erection. That happens with trazodone. And then weight gain, which can happen with the mirtazapine and the trazodone. Contraindicated in patients who are suicide prone, patients with anorexia and bulimia, seizure disorders, and cardiac or liver disorders. Other central nervous depressants, including alcohol, may potentiate sedation, so that's an interaction to be aware of, or increase the risk of seizures. Should not be taken concurrently with MAOIs, and it may cause lightheadedness, but if you take it with food, it's more likely that you will not have the incidence of lightheadedness. So it's something that you want to recommend that patients take with food. Anti-manic agents. Bipolar disorder, sometimes known as manic depression, is a mental illness that is characterized by severe fluctuations in mood extremes. So to very depressed, and then all the way up to very manic, very hyperverbal, very excitable. The cause is most likely an imbalance in brain chemicals that affect mood. The anti-manic agent listed here is lithium, which is the most commonly used for treatment of mania and bipolar disorder, and it helps to prevent more manic episodes compared with depressive episodes. Side effects of lithium are GI distress. Usually this happens initially and then resolves, but it's important to take the medication with meals. Cardiac arrhythmias and hypotension, low blood pressure. Thirst and polyuria. Dehydration may cause acute toxicity. Polyuria means you're overly urinated, you're urinating a lot. So that can lead to dehydration. Weight gain, tremors, and thyroid problems. Signs of lithium toxicity are drowsiness, confusion, blurred vision, and photophobia, tremors, muscle weakness, seizures, coma, and cardiovascular collapse. So lithium is one that they take the levels in the blood and they monitor you pretty frequently. We have to go get blood draws to make sure that the level is therapeutic because it is one that can cause toxicity in the body. Contraindications for lithium are seizure disorders and Parkinsonism, cardiovascular and kidney disorders, older adults and debilitated patients, and thyroid disease. Interactions. Other central nervous system depressants, including alcohol, may potentiate sedation, meaning it may make somebody heavily sedated if taken together, or increase the risk of seizures. Lithium cannot be taken concurrently with any MAOIs, and food may decrease the incidence of lightheadedness, just as I mentioned in the last one. Anxiolytics. Anxiety is the body's natural response to real or perceived danger. This natural response becomes a disorder when it is excessive and difficult to control and when it leads to significant distress and impairment. Types of anxiety disorders include social anxiety, post-traumatic stress disorder, panic attacks, and obsessive compulsive behavior. So the anxiety symptoms are out of proportion to whatever is actually happening around you. That's kind of what characterizes it going from normal anxiety to an actual disorder. Some anxiolytic agents, benzodiazepines, clonazepam, Klonopin, or diazepam, which is Valium. These are useful for short-term treatment of anxiety disorders, some psychosomatic disorders and insomnia, as well as alcohol withdrawal. Side effects include depression, hallucinations, confusion, agitation, bizarre behavior and amnesia, drowsiness, lethargy, and headache, ataxia, so difficulty moving and tremor, and they can increase the risk of falls in older patients by approximately 50%. So that's something to be very mindful of when you see this prescribed in the elderly. Rash and itching and sensitivity to sunlight. Contraindications are mental depression, suicidal tendencies or history of substance use, depressed vital signs, pulmonary disease, respiratory depression, pregnancy and lactation, children, liver and kidney dysfunction, and persons operating machinery. So these can make you drowsy. Someone should not be operating machinery while taking these. And I always think that that's kind of a funny, what do they mean by operating machinery? Well, using any kind of heavy equipment, but that also includes driving a car, right? That's machinery. You should not be driving when you're taking something that can make you drowsy. Interactions are central nervous system depressants, antiretroviral protease inhibitors, macrolides, azole antifungals, oral contraceptives, and calcium channel blockers. And then grapefruit juice can potentiate the effect of some benzodiazepines, meaning it can make the effect stronger. So that's an important piece of patient information. Other anxiolytics, buspirone, Buspar, and hydroxyzine, Vistaril. These are indicated for the treatment of generalized anxiety disorder, but not other anxiety disorders. And these do not have an activity against depression. So some people do have a mixed anxiety and depression. These agents would not be useful in that case. The side effects are dizziness, drowsiness, and headache, as well as GI effects such as nausea. Contraindications should not be taken with MAOIs, contraindicated in pregnancy, contraindicated for people who are taking diltiazem, and for people with kidney or liver disease. The interactions are benzodiazepines, increases the risk of CNS depression, and then alcohol or other CNS depressants should be used cautiously or not at all when taking one of these medications. Knowledge check. Which is not a contraindication to the antipsychotic drug haloperidol? A. Severe depression. B. Hypercholesterolemia. C. Diabetes. D. Pregnancy. And the answer is B. Hypercholesterolemia. Alcohol. Alcohol can be classified as a psychotropic drug. Again, remember, psychotropic, altering the mind, and a central nervous system depressant. It is a fast-acting depressant, and the body reacts to alcohol with excitement initially, but followed by sedation and finally anesthesia. Anesthesia means numbing or taking away pain. Large amounts of alcohol can result in alcoholic stupor, cerebral edema, which is swelling of the brain, and depressed respiration. Depressed respiration can then lead to hypoxia or low oxygen levels in the blood. Alcohol is rapidly absorbed from the gastrointestinal tract into the bloodstream. Alcohol abuse is common and can cause many long-term health issues. The graphic here shows alcoholism as a disease, and it says 10% of all adults are in need of alcohol treatment. When you really think about that, that's a staggering number, that 1 in 10 people would benefit from alcohol treatment. There is a range of addiction, and some people are what they call a functional alcoholic, where they're drinking too much, but they're still functioning, able to go to a job, etc. And then there's, heavy alcoholism. There's also people who are more social drinkers, but maybe it starts to develop into a habit. The CDC says that for women, 4 or more drinks on any day or 8 or more drinks per week consistently is considered heavy drinking. And then for men, 5 or more drinks on any day or 15 or more per week. There's also, if someone is relying on alcohol, they say, I can't sleep without having a few glasses of wine, that kind of thing. That starts to be a red flag that there's potentially a problem. Complications of alcoholism damage to brain function, heart failure, gastric ulcers, pancreatitis, cancer, liver disease, atherosclerosis, can also cause or contribute to high blood pressure. So when we talk about liver disease, as alcohol is processed by the liver, there becomes a hardening of the liver and scarring, and there's built up pressure that causes portal pressure that goes from into the gallbladder and can even go into the esophagus and cause something called varices, where there are outpouchings of blood vessels within the esophagus that can rupture and someone might be vomiting blood. So it's a very dangerous and scary disease. It's important that if people are getting treatment for alcoholism, they are typically taking vitamins to support their liver health, including thiamine. They are detoxing safely, because when you stop alcohol cold turkey, meaning just abruptly, and you're an alcoholic, you're going to have complications. You can have seizures, etc. And we'll talk about that on the next slide. And medications to help kind of titrate down and kind of help ease those symptoms as you are detoxing. There are definitely factors that contribute to alcoholism, including drinking under the age of 21, heredity, if you are raised in a household or have genetic predisposition to addictive behaviors. Stress can increase levels of alcoholism. And then alcohol use by pregnant women is very dangerous and can cause fetal alcohol syndrome in the newborn. Alcohol poisoning is also a very serious concern. Symptoms of acute alcoholic poisoning include cold, clammy skin, stupor, slow and noisy respirations, and alcoholic breath, so you can really smell the alcohol on the person. Acute, remember, means this is a new thing. It's happening right this moment. Somebody drinks way too much, and they have this acute poisoning versus something more chronic. And this can happen we see it a lot, especially in the ER. We see it in younger people who don't know their limits, people who are, partying, they're in their early 20s or even late teens. And it's very dangerous, and it can very quickly lead to even death. So it's something that we need to be aware of. Treatment of acute alcoholic poisoning includes close observation for respiratory problems. We need to make sure that the person's what we call maintaining their airway. So we may need to place an artificial airway or even put them on a ventilator tube if they're not able to keep their airway open. Vomiting. If someone vomits and they're already, and they're stuporous, they're confused, that they could aspirate or choke on that could cause them to lose their airway. Seizures. Seizures can occur both from acute alcoholic poisoning, but also they can occur during the withdrawal stage. Seizures typically do not require treatment unless status epilepticus occurs, which is when there are seizures back to back to back and we can't break that pattern for a certain length of time, like 5 to 10 minutes. That becomes what we call status epilepticus. Cerebral edema. Sometimes we'll use diuretics such as mannitol to help pull some of the swelling from the brain, but those come with their own risks. Electrolyte imbalances. Typically, it requires IV fluids with thiamine, folic acid, magnesium sulfate, and vitamins added, also called a banana bag. It's because it's like a bright yellow color based on the vitamins, and this helps to support liver health. And then as somebody starts to withdraw, they can have what's called delirium tremens, where they will have seizures, they'll be delirious. The worse, the more they have drank and then are withdrawing, it can be very dangerous. I have seen people with hallucinations. They don't even know where they are, who they are. They start seizing and they're sweating profusely. They're vomiting. It's a very, very serious condition. And again, it can lead to death. Alcohol withdrawal syndromes or symptoms are treated with IV benzodiazepines. Typically, what we give in the ER, we give something called phenobarbital. And we also give Ativan. Those are both stronger benzodiazepines that calm and help to kind of depress the central nervous system. Because while alcohol itself is a central nervous system depressant, when you are withdrawing from alcohol, your body needs some sort of sedation and depressant because there's no alcohol there to have that effect that your body has learned to rely on. So essentially your body's relying on the central nervous system depressant because you've ingested it so frequently. And so now you need to give it something to kind of wean yourself off of the alcohol. Symptoms of chronic alcoholism include frequent falling and accidents, blackouts and memory loss, dulling of mental faculties. So mental faculties is like your thought processes. It might be kind of a little bit slower to respond, not as sharp as you once were, irritability, and neglect of personal appearance or responsibilities. If you are working in healthcare and you have a patient who comes in frequently for falls or quote accidents or has trouble with remembering things, even if they don't smell like alcohol, because people can hide it really well, or they claim, no, I never drink, it's always something we want to be kind of suspicious of and make sure that we're monitoring for in case they do start to withdraw, and so that we can get them help. Treatment of chronic alcoholism includes vitamin B1, which is thiamine. That can be given IV, IM, or PO. Multiple vitamins and folic acid. A low carbohydrate and high protein diet to combat hypoglycemia. Elimination of caffeine in coffee, tea, chocolate, and soft drinks. And re-education of the patient with intensive individual, group, and family counseling, including Alcoholics Anonymous techniques. We cannot send somebody to a detox center unless they want to change. You cannot force somebody to want to change. And research supports that the change won't really happen until it comes from the person's own desire to change. And so this is just something to be aware of, because there are many times when in healthcare where you can offer all of the resources, but until somebody's ready mentally to make that step, the treatment doesn't usually come with a high success rate. Knowledge check. Which is included in the treatment plan for chronic alcoholism? Mark all that apply. A, vitamin B1. B, elimination of coffee. C, family counseling. D, patient education. And the answer is A, B, C, and D, so all of those. Vitamin B1, elimination of coffee, family counseling to get the whole family involved and supportive of the change, and then patient education. Elimination of coffee and caffeine, just so y'all are aware, it has to do with the stimulant effect of coffee, and one that can mask the depressant effects of alcohol if somebody starts drinking again, but also it can be addictive. It can alter dopamine production, and so as you're trying to heal your body from reliance on alcohol, we don't want to replace it with a stimulant during the withdrawal phase or afterwards. So it just has to do with the brain as well as the addictive effects and the stimulant effect versus the depressant effect. Prescription drug abuse. Prescription drug abuse is one of the most serious and fastest growing problems in the United States. Treatment of opiate addiction consists of a combination of counseling, behavioral therapy, and medications. The opioid epidemic specifically has been a very big topic, and it came about mostly the East Coast was where it was largely concentrated, but it's still a problem today. And it had to do with these new pain medications that were on the market that were not being accurately explained to people. They were being told they weren't addictive. They were being prescribed very irresponsibly. And actually, Dope Sick, it's a show that you can watch that's very good and very informative. I also really enjoyed a fictionalized book called Demon Copperhead by Barbara Kingsolver. And it's the story of a young boy growing up in the Appalachian Mountains who becomes addicted to opiates. And I just think it's an interesting topic to explore because, the medical profession was largely responsible for this opioid epidemic. There are other medications that are considered controlled that are more likely to be abused than other medication. This includes your stimulants such as Adderall, Ritalin. It also your benzos is another one, and some of the anti-anxiety type of medications, such as Xanax. So just some things to be aware of. Proper disposal and storage of prescription medications is important for deterring drug abuse. Keeping medications, especially those controlled by the Drug Enforcement Administration, the DEA, in a locked and secure space can help prevent theft of prescription medication. Disposal of controlled medications can be done in one of 4 ways. 1, disposing in the normal trash, but mixing with coffee grounds or pet litter to make them undesirable for consumption. 2, utilizing drop-off days at local government facilities or locating a drop box where they can be safely disposed of. There should be some in almost every city. 3, using a drug disposal system designed to inactivate drugs or make them unable to be accessed. This is oftentimes a liquid, and it's in like a sealed container. Something else I've seen people do in the home use is leaving a little bit of like laundry detergent in the bottom of an old bottle and then putting their pills into that. So it kind of dissolves into that. It's then not going to be able to be used. Flushing controlled medications down the toilet is the last one, but this is not preferred. If it's a last resort, go ahead, but otherwise we were going to try to use one of these other 3 resorts. Illegal drug abuse. 5 types of substances that can be produced illegally include heroin, amphetamines, marijuana, cocaine, and hallucinogens. Heroin is an opioid made from morphine, so it's a morphine derivative. It can be white or brown powder or a black sticky substance known as black tar heroin. Heroin affects the body in the same way prescription opioids do. It enters the brain rapidly and binds to opioid receptors, especially those involved in feeling of pain and pleasure, and those involved with controlling heart rate and breathing. Heroin is extremely addictive, and tolerance is achieved rapidly, meaning higher amounts are needed as time goes on. There are many negative side effects from using heroin, although the most dangerous effect is overdose, and the treatment for overdose is the reversal agent Narcan. So Narcan works against any opioid because opioids, again, bind to these opioid receptors. They saturate the receptor. And what Narcan does is it strips all of the actual drug off of the receptor. This means that when people wake up from getting Narcan, they are going to feel a ton of pain. They're usually vomiting. They're usually very upset. Just something to be aware of because you've just stripped all of their pain receptors of this opioid at once. Unfortunately, the way that the tolerance works as well is your body starts to think that if you do not have some sort of opioid in your body, that you're in pain. So if you don't have something chemical in your body, your pain receptors think, oh, I'm in pain because they're so used to being saturated with this opioid. Now, heroin is not one that you see as commonly, just to be honest, as fentanyl, some of the other, street drugs that we can get, oxycodone, those types of things. But fentanyl is the really big one in our area. And fentanyl is very potent in very small doses. So it's a very dangerous opioid. Amphetamines. Amphetamines can be produced and prescribed legally, such as Adderall, and they're also produced in illegal labs. The example of an illegal type of amphetamine is methamphetamines, also known as crystal meth, crank, ice, meth, or speed. Amphetamines cause emotional irritability, mental impairment, confusion, amnesia, and neurotoxicity. Unfortunately and scarily, there is no specific antidote from amphetamine overdose. So we are just trying to treat the symptoms when somebody comes in with an overdose. Treatment of an overdose is symptomatic and includes attention to airway, breathing, and circulation with the administration of sedative drugs because amphetamines are uppers or stimulants. Abrupt withdrawal of amphetamines may unmask mental problems. Therefore, patients require careful supervision during withdrawal and long-term follow-up may be required because of some manifestations. Methamphetamine is a nasty, nasty drug. because it can cause this mental impairment and this neurotoxicity. As it's shared here, we oftentimes, when people abuse methamphetamines, when they come off of them, they will develop schizophrenia. Something we say a lot is which came first. So some people with mental illness such as schizophrenia will choose amphetamines because they like the way they feel on it, or they feel more managed, or the amphetamines can cause schizophrenia and other psychological disorders. And amphetamines are very, very big in San Diego County. It's one of the more common overdoses that we see. They can be injected, snorted, smoked. There's lots of different ways that folks ingest amphetamines. Marijuana. Now, marijuana is legal in the state of California with certain stipulations and guidelines, but it is still federally an illegal drug, so it's going to fall under this illegal drug abuse category. Tetrahydrocannabinol is THC, which is the active ingredient in marijuana. Although it's technically classified as a central nervous system depressant, it also possesses properties of euphoriant, sedative, and hallucinogen. When not regulated, its composition varies widely, and the methods of administration do not provide a standardized and reproducible dose, meaning even within the same batch of marijuana or the same crop of marijuana, if it's grown naturally, it can vary widely how potent it is, which can be a big concern, right? If somebody is taking something that they think is going to be a small dose, but it's more concentrated, etc. Dispensaries with licensed pharmacists are available for patients to get marijuana prescriptions filled. Side effects include short-term memory loss, impaired learning, and slowed intellectual performance. There are other names in the illicit synthetic cannabinoid classification, such as spice, K2, skunk, and fake weed, which typically have a hallucinogenic effect as well. These are also more dangerous and can be more potent. These products are abused by smoking and contain dried plant material and chemical additives that are responsible for their hallucinogenic effects. Another thing to be aware of in our community is that there is a lot of laced marijuana, including marijuana laced with fentanyl and marijuana laced with LSD. So a patient may think that they are, smoking something, and they may think this is medicinal for me. I've used it before, and it may be laced with something more dangerous. Cocaine. Cocaine is a central nervous system stimulant and produces euphoria and increased expenditure of energy. Cocaine is highly addictive, causing dependence even after short-term use. It's abused by intranasal application, sniffing or snorting, intravenous injection, and inhalation. Severe depression can be associated with withdrawal, which is a lengthy and difficult process because it's this very intense stimulant. When you withdraw, you can have central nervous system depression and mental depression as well. Side effects include hypertension, chest pain, tachycardia, which is rapid heart rate, cardiac arrhythmias, stroke, and respiratory failure. Cocaine is also known to cause tremors and seizures. It is such an upper that it can overstimulate the central nervous system. Cocaine is one that's very dangerous. Even just one very strong hit could lead to death if there's not, especially if there's other factors involved. Cocaine is also known as many different things. All of these drugs have many different street names, but crack is another, it's a version of cocaine. So it is cocaine, but crack tends to be a little bit cheaper and tends to be something you'll see abused more frequently amongst many of the population. Lastly, hallucinogenics. Lysergic acid, which is LSD, and phencyclidine, which is PCP or angel dust as a street name, are animal tranquilizers. They are used as that, but they are also used as street drugs. They are hallucinogens. Other hallucinogens include psilocybin, salvia, ecstasy, ketamine, just to name a few. So that is a pretty extensive list. Those are the ones that we most commonly see abused, but all of those fall under the hallucinogen category. The other one that I've seen, interestingly, is peyote, that I've seen people come in with very, drastic effects from peyote, and they're, hallucinating and that kind of stuff. They have psychosis from it. Hallucinogens produce bizarre mental reactions and distortion of physical senses. Side effects include increased pulse and heart rate, a rise in blood pressure and temperature, and a possible physical injury to self or others due to psychotic episodes, panic, or paranoia. Especially if somebody is already prone to panic, anxiety, or paranoia, these can be very, very dangerous drugs and can also facilitate worsening of mental condition. Knowledge check. Which illicit drug affects the body the same way prescription opioids do? A. Marijuana. B. Cocaine. C. Hallucinogens. Or D. Heroin. And the answer is D. Heroin. Case study. A 28-year-old patient is transported to the emergency room after being found in an alley, unconscious but still breathing. The physician orders a full lab workup to determine the patient's condition and cause of unresponsiveness, decreased respirations, and slow-moving pupils. While waiting for stat labs to come back, they notice a white powdery substance in his nose. The medical staff runs a quick test and determines it to be heroin. In an attempt to regain consciousness, the initial emergent treatment would be A. IV saline, B. Narcan, C. Fluoxetine, D. Clonazepam. And the answer, because heroin is an opioid derivative, is Narcan, B. Narcan. Role of medical personnel in combating drug abuse. What is our role as medical personnel? Our role includes understanding psychotropic drugs, actions, and side effects, participating in the education of the family, the patient, and others in the community, giving competent care to those under the influence of drugs in a non-judgmental way. And this includes really prioritizing safety, because depending on the type of drug, we need to be monitoring their cardiac status. We need to be making sure they're not falling, that they're not hurting themselves or others, especially during a psychotic episode or where they're having delusions on something that's a hallucinogen. Recognize drug abuse and make appropriate referrals without exception. So everybody should have the opportunity to have follow-up. What we do in the ER, we have something called a substance use navigator. So we fire a consultation in the order set so that this person will come and speak with the patient before they go home and get discharged, to give them follow-up information or to help arrange for them to go somewhere where they can get treatment. And then complete an accurate record keeping of controlled stock of drugs that could be considered potential drugs of abuse. In my role as a supervisor at the ER, once a week, we do a controlled substance count with another nurse. So usually the manager and one of the supervisors goes through and counts every single medication, make sure that when they are being pulled from the Pyxis, which is our medication dispenser, that nurses are not falsely calculating or taking any that we're not short anywhere that we shouldn't be. So it's a very serious thing. And then also, if you are a prescriber, a physician associate, an NP, you need to make sure that you are giving the appropriate amount. They usually dispense them only in small amounts at a time and require reevaluation of the patient before we're giving them more medications that could be considered high risk for abuse. It is the responsibility of all medical personnel to recognize drug abuse and report any observed drug abuse to the proper person in authority. Looking the other way not only enables the individual to continue to harm themselves, but also endangers those in their care. There are many services available to help medical personnel deal with drug abuse problems. The following are resources that can provide information. Just something to be aware of is that medical personnel tend to be at actually very high risk for narcotic abuse, specifically because there's access to those things and because of high levels of stress. Alcoholism as well tends to be rampant within medical personnel. The National Institute on Drug Abuse is one resource. The National Institute on Alcohol Abuse and Alcoholism of the National Institute of Health. Substance Abuse and Mental Health Services Administration. And then Alcoholics Anonymous and Narcotics Anonymous, which is AA and NA. Knowledge check. Which is not a role that medical providers serve in combating drug abuse? A. Provide non-judgmental and competent care. B. Refer patients who are only repeat offenders. C. Willingly participate in the education of the patient. D. Understand psychotropic drugs and their actions and side effects. And the answer is B. Refer patients who are only repeat offenders. Remember, we should be referring everyone without exception if we think that there is a drug abuse or an alcohol abuse problem. Self-assessment. What are the psychotropic classifications discussed in this chapter? What complications does alcoholism cause to the body? What are the roles of medical personnel in combating drug abuse? Thank you for listening.